Hello, everyone. I'm Gabriel Lopez, board member of OutCare Health. My pronouns are he, him. Thank you for joining us for OutCare's Talk Series, a webinar series devoted to discussing diversity and intersectionality within the LGBTQ plus communities. We have many people across the world tuning in today. We want this to be a safe and welcoming space for everyone, so please feel comfortable asking any questions today. All OutTalks are recorded and can be watched on our website. I am very excited for this OutTalk, Beyond Barriers, Community Centers as Pillars for the LGBTQ plus health equity. And today we will hear from inspiring people doing amazing work across the country, including myself. And I am very thankful for our moderator today, John. John, take it away.
Hooray. Thank you so much, Gabriel, for sharing with us. Once again, my name is John Sovak, and I'm your host today and moderator, and I'm really excited to have this panel together and having this conversation. We like to start off our day with everyone introducing themselves, sharing a little bit about who they are and the work that they're doing. And they get a secret bonus surprise question that they have not heard until this very moment. For today, we're going on the music direction. So if I grabbed your phone right now and went to your playlist, what's on the top of your list right now? What are you playing and listening to over and over and over again? Okay, so that is your bonus introduction question. And I think we'll start with Amy today, if you're ready to go.
Yeah, thank you, John. So happy to be here. My name is Amy Starr, and I am the Talent Engagement and Retention Manager for Chaz Health. We are an FQHC based out of Spokane, Washington, with 22 clinics and serve people of all walks of life. And I would have to say that I am listening to a lot of The Weeknd and Maxwell on my playlist lately.
I like it. Kind of moving yourself around a little bit there, huh?
Absolutely.
Fun. Corey, share a little bit about the work that you're doing, and don't forget, you got to know what's at the top of your playlist right now.
Yeah, so I'm Corey, they, them, or she, her. I'm the Director of Health Equity at CenterLink. I've been in that role for just over a year, but I was a volunteer and a consultant with the program for 11 years before that. I'm a lawyer by background and moved into the public health space, and my role at CenterLink is to support our 350 community centers across the country who are members who are doing health work. Not all of them do direct health services, but I help them in anything health related. And my playlist is pretty much just audiobooks. I think the last music that I listened to is the soundtrack for I Saw the TV Glow, which is a really cool independent movie that might interest this particular audience. So check it out if you haven't already.
Cool. Thank you. Gabriel, it's to you.
Hi, my name is Gabriel Garcia Lopez, pronouns are he, him, and I am the Director of Health Information Systems for the Los Angeles LGBT Center. We are an FQHC located in Hollywood, California, providing services across LA area for LGBTQ plus individuals. So yeah, and on my playlist, always have Orville Peck. And right now, sort of been listening to Chappell Roan. That's been really fun and their music is great. So yeah, that's on my playlist.
My husband will be very happy to know that you're listening to Orville Peck. He's obsessed with Orville Peck and like has been since the beginning. So once again, my name is John Sovak, and I'm a therapist located here in Pasadena, California. My pronouns are he, him, and I specialize in working with LGBTQIA plus youth and their families during the coming out process. And I'm also the author of Out, a parent's guide to supporting your LGBTQIA plus kid through coming out and beyond. And I'm very proud to share that it's actually been on the literary awards circuit recently, and I've been winning a couple of really cool prizes, something I didn't see happening when I brought this book out into the world. And I do want to make sure and say happy Pride Month to everyone who is joining us right now in the middle of June. In this month, we celebrate our communities, we celebrate our resilience, we celebrate our history, we celebrate our pride. And I think it's more important than ever because right now we're in a time when hatred and vitriolic language is just running rampant all over the airwaves, whether it's on social media or in the news and just in conversations that all of us are experiencing in our day-to-day life. You know, Pride in Healthcare is our chance to show our support for our community, for our patients, our providers, and our LGBTQ partners who are standing with us. If you want to learn more about the work we do, go to outcarehealth.org/pride to hear from our sponsors, our featured providers, and to donate in support of LGBTQ health equity. And if you're considering doing a donation, remember, if you're with a company and they've got corporate match, always a great thing to include in the process because it can sometimes double any contribution that you might make as an employee. So with that said, let's just kind of jump into our conversation today. And I think for myself, it's really important to understand, like as community centers and people who are working in community centers, where do you see the place of a community center, FHHQ, in the community itself? Like, what is the focus? What is the center core? What is the foundation that you provide to a community as an agency in this type of work? And Amy, just because I saw your head nodding, I'm going to toss it over to you. I saw the head nod.
I will jump on that, John. Thank you. Well, as a federally qualified health center, we are always keeping our ear to the voice of the patients. So our board of directors is made up of patients who speak to what they want to see from their vantage point in the community. So we strive to provide that. So when COVID hit, we took a leadership role in providing vaccines in our arena downtown. So just being nimble and responsive to the voice of the patient, that is really what we hold most precious as a community center for healthcare.
Yeah, working for same thing, Amy. For the LGBT Center, our mission is to create a world where LGBTQ plus individuals thrive as healthy, equal, and complete members of society. And so our mission is always focused on that. And the way that we do that as a federally qualified health center is that we're providing that safety net for those individuals, for people who have been turned down or turned away from a health system that is complex or provides stigma. We are providing that first level of care for people that have otherwise been let down by this system. I can think of other events like monkeypox. So there wasn't a response that we were seeing nationwide. And so what our organization did is we took charge in that, and we were able to provide the same level of vaccination support that we had for COVID, but doing it for monkeypox, which was something that was being highly overlooked, especially for our communities. And so what we try to do is really spotlight issues that are affecting specifically our community and providing those care opportunities and touch points for people that otherwise might not receive it elsewhere. And so that's how we are supporting our mission of letting people thrive in a place and time that it's getting difficult more and more for our community to do so.
That helps me answer the question as well, because the LA Center is one of our 350 members and one of the founding members of CenterLink. So CenterLink is basically an association of LGBTQ centers where we provide them with all different kinds of supports and services. So I can't give one answer to the question. I can give 350 of them. And I see some of our member centers here on the folks from our member centers here on the meeting as well. So I think we see our centers providing a huge range of services. Some are mostly, social type services for people to be able to interact with each other. Some have really, robust health services. Some are doing a little bit in the health space, and that which may have been how they started or something that they added. We have centers that are serving just youth, just older adults, just trans folks. Everything that you can imagine. And a lot of them are increasingly virtual, or they may move between different spaces and go meet the community where they are. So I think the overall theme is that they're doing something for the community that no one else is doing, often working with populations who are overlooked or who want to, be receiving services and having shared community with people who are like them in one way or another, in a way that they don't get outside of that space. And beyond that, the array of what they provide and what they do is really a wide range from among those 350 members.
And Corey, maybe this is a question that I can start with you, like looking at those 350 member centers. What do you see as the major differences, strengths, challenges between city-based centers and more rural-based centers? What do you see as the differences that are showing up there?
I think, some of the things that we might typically think of in answering that question might be things like transportation differences, tending to be stronger in cities, policy and kind of cultural environments for LGBTQ people being better in cities, more resources in general in cities. I think those are kind of like our starting assumptions, but I think that the more work that I do, I see that there's a lot more nuance to it. Our cities, our centers that are in cities, most of our cities in the US have really terrible transportation. And so a lot of times the centers are still having to go out and send mobile units or open multiple spaces or move around because there's no way for people to get to one central location within a city. A lot of times the centers that are based within an urban area are also serving people throughout the county or even surrounding counties. So there's quite a bit of a mix with some of the centers as to whether you would even consider them urban or rural. So I think there's really a range, and so I think it's a little bit tough. But I think in general, the folks that are working in more rural areas, especially right now with there being a lot of policies targeting transgender healthcare in particular, as bad as the resources are in some cities, it's worse in the rural areas. Really hard for people to access services, and it's really hard to kind of have any sense of being like anonymous in a rural area. If you're in a small town, there may only be a couple providers. Everyone kind of knows everyone, so it can be really hard for youth to. I'm thinking more youth here, but adults as well, to be able to access services safely. So I think that there are some differences, but I think it's probably more of a spectrum and some overlap with some of the urban centers and some of the rural centers in terms of the issues that they're facing.
Mhm. And maybe Amy and Gabriel, what insights do you have on that?
Yeah, I could tag on to that we really try to provide continuity in care. For example, someone receiving gender affirming care, we would want to make sure that that individual has everything coordinated, from the hormone blockers, hormone replacement therapy, surgery, referrals, and behavioral health care if needed, so that those are as seamless as possible and don't feel like they're fractured and difficult to access amongst multiple outsourced providers. So that is much easier in a more urban setting. It becomes more challenging in our rural communities, but at the same time, we have community health workers and social workers who can be a conduit of care and check in and really kind of help be a warm presence for our patients who need that continuity. So I would say continuity of care is the biggest challenge between our larger urban areas and our rural areas.
Mm-hmm.
Same, I have to agree with that. While it's easier in an urban area to provide that continuity of care, I think just navigating the healthcare system, even internally, with the right referrals, ensuring that we're getting the right providers lined up, because we while we provide a lot of that coordination of care, we're relying on specialists to refer people out to, and so I think that becomes kind of the challenge for us. And so what we strive to do is, through virtual care, through virtual visits, through digital engagement, trying our best to make sure that we're walking our patients through that journey, and helping them along the way, and helping navigate this complex healthcare system that often can miss a lot. And so I think that's where we find a lot of challenge, on top of the staffing issues and constantly changing priorities within an organization, legislation that is seeking to make it even harder for us to provide it and deliver the care that we want to provide to our patients. So, yeah.
And Gabriel, you bring up an interesting point. How do you all feel that virtual engagement has changed the role of community centers and FQHCs in the process of creating access to care for the LGBTQ plus community?
I think it's been a huge asset because we still have those who have dysphoria in the healthcare setting that's, it's aggravated by a lack of education and awareness in those environments at times. And that comfort of being at home and receiving, virtual care can help someone stay engaged with their healthcare plan at times where they just may have trouble. I may say, today I just want to stay in and I want to flip that appointment to virtual, and that's just going to make it easier. Now, ultimately, if we ever hear of an experience that's dysphoric for anybody, we want to jump on that and see, what happened, where was the wrinkle, and what can we do to make things whole, make things right. So constantly vigilant about that. But I think just having that option can bring a great comfort to our community members.
For us, we've really seen the benefit from our behavioral health or mental health department being able to expand that by almost double to really address those needs. And so that's just become our standard of care. And since the pandemic, we've moved most of our therapists off-site and they're providing remote services virtually. But we, of course, rely on those reimbursements to happen. And so we hope that that doesn't change in a way that's going to be negative down the road. But it's allowed us to shift and provide a better footprint in our organization at our building to provide in-care services and moving the services that can be remote, which have been a lot of our mental health and behavioral health services offsite. So it changes the landscape for us, but also building the capacity with that flexibility in virtual care.
And I would agree with all of the positives, but maybe just throw in some, not to be negative, but just to throw in something different. That I think that we definitely saw, obviously, a huge decline in in-person services even after COVID. Once people were allowed to come back, I think some folks, kind of got used to doing things virtually. Some of the centers are still struggling with getting people back for in-person interactions. And, I worry that a little bit of the sense of community has, been lost there. But we will know more in the fall. We do a huge survey of our centers every 2 years. And so we have one that's being done this summer that will be published with Movement Advancement Project in the fall. And that will be our chance to see kind of where the numbers have gone, as well as to see a better snapshot of how many services have returned to mostly in-person versus, our hybrid or are staying online.
And Corey, just for everyone who's joining us today, will that be something that it will be a report available to the public?
Yeah. Movement Advancement Project is our partner in that. They have a great library of different types of reports and research online. And so this is the community center survey. And so, yeah, it'll definitely, they will have that on their website.
It's a good point that you bring up, Corey. Two things that we're looking at is we eventually see that patients like a telephone visit versus a video visit, but we know that reimbursements are going to be heavily focused on video visits, and those are where the reimbursements are going to lie. So we're having to shift to ensure that we have the right digital tools to provide the best, easy to use type of video visits. But then how do we also incorporate bringing somebody in at least annually so that we have policies in place to kind of ensure that, it's not just completely virtual visits, but we're bringing somebody in, encouraging them to come in, because from a medical perspective, we need that balance. We need something, that in-person care, building that community. Also, there's just requirements on their medical care to come in and see their provider.
Some of us need a little kick to get back. I get all of my care from a queer health center, and I haven't been in person since before COVID. So I'm as guilty as anyone.
And I think, Corey, you brought up a point earlier that I thought was really interesting, and it applied to some experiences I've had in the work that I do. This actually happened in Hawaii. I was working with one of the healthcare centers there, and in their entranceway, there was seats out in the general entry. They had like a glass wall, came into the counter, you could sit there, or they had another room that had you couldn't view into. And we were really curious about that when we went to do this training, and we talked to them. And one of the things they talked about is, in a more rural community, which they consider themselves to be, anonymity is really important. that the idea of even coming to this healthcare center was in some way potentially outing them to a community that was very small and talked a lot and had lots of viewpoints about why someone might be going into this type of center. So I think that's another piece of the puzzle when we look at this difference between, rural and city, is this idea that for me, if I'm in a small town and I go to the center for LGBTQ healthcare, there's a real likelihood that I'm outing myself in a way.
Yeah, we have, I went and visited a center this summer that had moved from the main street into a kind of an office building a little bit off, right? For exactly that reason, that people liked having a little bit of separation, a little bit of privacy. Security is also a huge issue for our centers lately. There's been a lot of vandalism, threats. And so, that's another consideration beyond privacy is safety as well.
Yeah, and I think it's something for, providers who are joining us today to really be aware of, and the consciousness of how your community is connecting and viewing you. And for those of us who are with us live today, if you have any questions, observations, experiences you'd like to share with us, you can put them in the Q&A and we'll bring them up to our panel. You can also drop them in the chat and we'll try and keep track of them there as well too. And just kind of looking in general, I know, Gabriel, you've mentioned a couple of these already, but what do you all view as some of the more unique challenges of trying to fully staff a community center, both rural and in an urban setting? What do you see are the challenges that are arising, especially as we're like coming back from kind of a pull-in section during COVID, like trying to expand out and provide services? What are you seeing out there? So either two things have happened. I've talked too long or my question was not clear. I've done this before and I'm aware of it.
Staffing challenges, right? Okay. We recently found that we've wanted some more of our teams who were remote for the past few years to adopt a hybrid schedule. And not everybody's on board with that. So employees who came on board in 2020, 21, 22, it's tempting for some of them to think, I'm locked in, my home base, this is it. And nobody's going to rock my cozy situation. And some of our leaders have concluded that, a hybrid would be preferable for more face time with the team, and just access to really just that interaction at the human level. And so we've been going through a few bumps with that. And we'll continue on that journey. It'll be interesting to see where society lands in the workforce with the percentage of people that continue to work remote versus in an office. I mean, we've even seen real estate change because of that whole shift. So, and we've had a huge real estate boom in the Pacific Northwest that we did see rural areas getting a lot more people moving there because they thought, well, I can work anywhere. So I'm just going to build my dream house out in the woods. And so the thought for those folks to have to go back into an office is just, it's forget about it. So that's definitely an element. Our mission is very broad in servicing the needs of the community and creating access. So ideologically, people probably screen themselves out. There's the occasional time where someone realizes that, you know what, maybe this isn't the right bus for me to be on, but that's very, very rare. And we're up to about 1,800 employees now. So there's a singular focus on meeting the patients where they're at. And so that is not difficult. I think just having a strong mission really does help market to the community and have people want to get on board. Hopefully it's the word of mouth through patients saying, hey, I had great care with Chaz Health. I'd recommend them. That's our best way to get staff, is because they hear from friends who are either patients or employees and they want to get on board.
Working FQHC work is very rewarding work, but it's also hard work. And LA is becoming very expensive, and I think a lot of people are finding it, there's a struggle with that. There's a struggle from staff members working a nonprofit. You feel it. You feel it as the rising cost of living is happening all around you. You feel it with patients that are also experiencing that. And so it leads to this general anxiety around just frustration, coupled with provider burnout, caregiver burnout. I think we're all kind of experiencing that. I know I feel that too, and competing priorities. And there's so much regulation that FQHCs are placed upon, or that are placed upon FQHCs. So, there's always this drive and requirement to operate at the best you can be. And I think it finally makes its way down to the staff and workforce. And like you were saying, moving people back to a hybrid mode or coming back on site where once you were working from home in the comfort of home. So I think when you start thinking about all of these issues that kind of converge in today's political climate, that anxiety around that. So sometimes it feels like no matter which direction you turn, you're met with something to keep you up at night or to be anxious about. And then having to go to work and doing work within an FQHC. At least from my perspective, that's kind of what we've kind of seen. But then at the end of the day, it is rewarding work, and I get up every day because that's what I want to do. And I think everybody else at our organization also feels the same. But there is that burden we all kind of hold as well collectively.
Yeah, I think that sense of the political atmosphere for queer folks and trans folks, we are constantly hearing about burden at centers, burnout rather at centers among staff. I was talking at a meeting today with folks about vicarious trauma. So communities are going through a lot, and then the staff are often part of those communities themselves and are serving the people who are coming through the door. That's very challenging. So I think it's hard work, and being a part of the community that you're serving can be, as you said, very rewarding. But it also means that what they are going through, you are going through. That's a great point of connection and a reason why people, come to our centers for services, because people there understand them and are part of their shared community. But that's also a lot of pressure and stress that is put on the staff who are doing that work.
Mm-hmm. Yeah. And I think compassion fatigue is a very real thing that people who want to be part of these community-based organizations face quite often, because the balance between quality of living and, actually providing the compassion that you want, it's a hard balance sometimes. And, especially when we're looking at rural communities, we're looking at this idea, you may be the one provider like in a 500-mile radius. And that puts a lot of pressure to keep the doors open, to be there, to answer questions at all hours of the day. And I think that's something real. And, Corey, what you addressed as well, too, is yes, compassion fatigue is there, but also we are also in the middle of the PTSD as queer folk, facing the exact same things that every one of our clients is facing. And a lot of clinicians that I'm talking to currently are really having difficulty like finding that balance of taking the best care of themselves while still trying to be there for their clients and patients. So what role do you think community centers have in activism, advocacy, political forums? Where do you think community centers place in that equation?
Well, I think one of the main things that our centers do is education, both formal and informal, so trainings in the community, to, whether it's to healthcare providers or to other nonprofits or at schools, governments. That's a big service that they provide, but there's also all of the informal education that goes on, right? Even having the flag outside on the window or on the door, bringing visibility to the community. I think that that's advocacy in and of itself. So I think that there are all of those things. And then our centers are also really engaged in more formal types of advocacy. So, working with their local officials, speaking at their state house, helping to register people to vote. A lot of activities like that. We have an advocacy arm of CenterLink called ActionLink, where we have different ways that people can participate in like federal comments for different types of health regulations or sign-on letters and that kind of thing. So there's definitely a lot that happens even within the regulations around 401c3s that centers are doing. But I really think that just being out there and being visible at a time when that's still not easy in a lot of places is a political act in and of itself.
I would echo what Corey shared for our FQHC being visible in the community. And one thing I would add is that we have been bringing clinics into the public high schools so that young adults and tweens can get confidential care. Now that's become a big challenge in Idaho, which nestles right up to Washington State, but we do provide services in Idaho, so we've been really hindered by the legislation there. But we are working through that best we can. But being present in the high schools and establishing a rapport with the young people so that they can be advocating for their reproductive care, testing, whatever they need, and have that trust and comfort to come in. We give them free snacks, free food, just so they can come hang out and feel comfortable. So that's the direction we've been really going and building on, and that's working well.
The Los Angeles LGBT Center, we're not just an FQHC. That is one part of what we do, but we also have a huge policy and advocacy team that do go out to state, local, federal governments and are able to advocate for us, stay abreast of what's going on with the climate, political climate, and bringing that information back to staff, making that way back to patients. And then I think it's also just important to be connected or connect yourselves. I sit on a few boards where that's my opportunity to raise awareness or bring that information, share best practices, exchange ideas, promising practices, and then take those out to other areas that it may not be as visible. If you're familiar with HIMSS, the Health Information Management Systems Society, they have a global conference every year. And so I try to make a point to go there and speak and have the global stage just to say, hey, we that conversation, that dialogue needs to stay present, needs to stay relevant, needs to be in the ears of people where it doesn't often land on. And so I try to make it a point to ensure that as our other staff members at our organization is really using professional networking and associations to really raise that awareness, educate, advocate, but at the very least, just raising awareness.
Mm-hmm. And if you're all okay with this, and you can tell me, no, I don't want to go there, John, it's okay. We have a lot of people here who are working at centers throughout the US, some of them in bigger areas, some of them in smaller areas, but it's hard. There are some days when it's hard. There are some days where, see, now I'm going to get emotional. Let's just go with it. There are some days when the news will come up with something that just tears my heart out, and putting myself together in the morning and getting ready to go out and do the work that I do is more challenging. So if you feel comfortable, how are all of you doing? Working for these agencies, being these public faces, being someone who is constantly putting yourself in an environment of having to speak up and speak out. How are all of you doing?
I'm doing well. But I would say that like that, I have my job and my work life and then my personal life. So I'm advocating, and doing that work 8 hours a day at work. And I'm not always in the mood to advocate at 5:01 when I log off. So, I'm not always going to correct someone using my pronouns or educate people while I'm out, right? It may be easier for me to present in a certain way depending on where I'm going. knowing what bathrooms are going to be available to me to go out and what that means and how I should dress to go there, right? So I think I navigate, my personal life maybe in a way that's, not what I would tell someone as an advocate to go out there and do. But I'm kind of expending a lot of that energy during the workday. So when the workday is over, sometimes, taking the path of least resistance and not continuing as an educator and an advocate, in the personal life, even though that's, I mean, ideally we wouldn't have to do that at all, right? So we make it work.
Mhm.
Being patient with myself and understanding with myself and being patient with others. My husband and I have a thing where we try to avoid decision fatigue. So it's like we'll tell each other, okay, you just make the decision, that's going to be fine. Where we're going to eat or something. Like it's those little decisions sometimes that you just don't have the energy for. And so for me, it's finding those little opportunities just to make life just a little easier when I disconnect from work, because that's something I have been very adamant about is, 5 o'clock rolls around, that email can wait till tomorrow. There's often nothing that's going to be needing to be acted on today. So I will let it go until the next, tomorrow morning. So again, it's paying attention to myself, my needs, and being able to give myself that time to recharge, and then allowing that time to be with family and friends.
Mhm.
I love that, Gabriel. I was just on Teams with one of our employee advisory council members, and I facilitate that group. And they know to reach out to me if they've come across something that they think the organization could be doing better. And every time they've come to me with something identified, and maybe it's something like, oh, the wellness room seems to be only getting used for lactation at this one site, and we need it also available for binding relief. Okay, great, I'm on it. And that can be tedious at times because it just feels like just chipping away, pushing, the ball up the hill. And I have learned that we need to just stop and celebrate those little wins, like, yay, we got the lactation room expanded to just general wellness. Yay, let's just take a moment and have gratitude for the small things. And that has helped me tremendously to have some levity and just find those moments of joy and things to celebrate. And Pride Month is such a perfect reason to celebrate those things. I have to admit, though, at lunch I was looking at the news and I read about Samuel Alito's wife wanting to put out a shame flag, and I just thought, how can this even be happening? How can this even be the state of our country? And it's just moments like that, having lived through the similar feelings in the 90s. It feels like a bad flashback sometimes to situations that I thought that we had moved far beyond. But there's this sense of whiplash, flashback, and I don't know if others can relate to that who experience the slow, painful changes. And now we just see regression. So self-care is really important. And I'm glad you brought that up, John. Thank you for the question.
Well, and I think it's important to share with people who are joining us today to understand whether you're in Omaha or Indianapolis or Palm Springs or somewhere in the middle of Texas, that all of us in the queer community are going through this right now. We are, in our own ways that are very personal to us. And I know one of the ways that I have to manage it for myself is I have to put myself on a very careful social media and news diet. From Friday to Monday, I do not go on social media. I do not read any news. I figure if anything big enough is happening in the world, someone will mention it to me in passing. But it's one of the ways that I have to take care of myself, to pull myself out of that information loop, to just do simple things like work in the garden or have friends over for dinner, or like you say, Amy, just laugh at a funny movie or a joke, or watch the dogs be silly. So that's one of the ways that I've had to manage it for myself, because as a queer community, we are a central target right in the middle of the bullseye at this moment. And for those of us who are trying to do the work, and those of us who are just trying to live our lives as openly queer people, it's a really challenging time. So I hope all of our providers all over the world are hearing this message and knowing that we're all going through something together. I think it's so
Yeah.
important to recognize that.
And to just really like remembering what it's like just to be able, we were talking about virtual, like being remote and whatnot, but being in person and connecting. We have a happy hour with some of my team tomorrow, and I'm looking forward to that because this past weekend we were supposed to be on site working on an upgrade. We're having an upgrade with our systems, and we were told that we couldn't because there was a potential bomb threat that was going on at our location. And I remember getting on Zoom with my teammates, and I just wanted to reach out and hug them. And, we had to make adjustments and everything was okay, but it's just a reminder that this is our reality. And so I'm really looking forward tomorrow to going and hugging them and like connecting with them in person. And so, yeah, it's always those reminders that, that's out there, but then there's also the beauty of being able to connect with our team and having that person-centered kind of just approach to connecting.
Mhm. Thank you all for their going with me. I just think it was really important to bring into this moment. So, looking at the organizations that you're working with, what do you see as the potential growth places for you and your organization? What do you believe community centers and FQHCs need to grow with? Where do you think they need to go? What are some of the focuses that you see coming up in the future? Or places where you're trying to like patch up some missing parts of the equation?
Well, I can say that CenterLink has been growing as our centers have been growing. So we were founded 30 years ago, and over time, centers in general, LGBT centers have grown a lot. So at the beginning, CenterLink was mostly supporting executive directors and board chairs because that was often like those are the only people kind of making the whole thing run. Now that centers have larger programs, we're increasingly supporting program staff, which is why my job exists. We have someone who works with youth staff and youth programs. I mentioned someone who does works in advocacy. So we're kind of growing as the centers are growing, and as their services are diversifying, we're trying to diversify our staff to have people who can support them, so that they're able to share resources and network and not have to kind of reinvent the wheel. If someone's doing a program for older adults, that we have someone who can kind of connect them to resources and grants and things that are in that area. So we're basically matching where the movement is growing, which I think is in general getting bigger and just more greater diversity of services and more targeting specific populations within the community, whether that's people of color or it's trans and gender nonconforming folks, a lot of services for older adults. And we kind of follow where they take us.
We have been growing our street medicine and mobile medicine services. So that's where we can continue to grow to meet the needs of our smaller communities that just need a mobile unit to come for the day and just be available to the community, parked at at a school or a church or a library. And our street medicine is in the city environment, seeing patients on the streets who need, maybe diabetes, need their extremities checked, just need immediate care. So our providers who do that work, we need to keep them strong and keep them resilient. It's hard. They carry it with them, and any procedural policy change or just about anything at all just seems so minute and insignificant compared to the work that is being done on the streets and the things that they're seeing, the trauma that those teams are witnessing, and keeping that education available to all of our workforce and our community members to know the benefits of that street medicine, to help people literally get on their feet and be walking and be able to then be able to try to look for a job and get kind of get their foundation back under them. So that's something I think we can continue to be doing more of.
I think we are exploring new avenues and opportunities for reproductive health, ensuring that we're meeting the needs that might be not widely available throughout the rest of the country, with the political climate and landscape. But I think before we do that, while we have become a large organization, we're finding opportunities to transform. So practice transformation, digital transformation. How do we do things better? How do we de-silo? How do we create a strategic framework that really solidifies the way that we take care of our patients in the digital tools that we use, and a lot of what I'm working on right now and leading efforts on are making sure that we have the right tools and resources for our staff to be able to provide the best level of care for our patients. And in that, how do we incorporate the advocacy and education, letting vendors know how do we take care of our community the best way possible? Do we have pronouns correctly going into the different parts of a chart that's going to be meaningful for someone? Are we capturing gender identity and sexual orientation in a way that's meaningful for somebody? Are we really providing, and do we have our EMRs kind of talking to each other and building rules for clinical decision support that accounts for any aspect of somebody's who somebody is, to make sure that their care is being delivered in the best and most meaningful way possible. So that's kind of what we're doing, is not so much from a growing perspective, but transforming. And I think we're really excited about what that looks like for the center.
Mhm. Yeah. And Corey, I did not know CenterLink was over 30 years old. That's amazing. That's really cool.
Yeah, celebrating our anniversary, and it was, as I mentioned, the LA Center, one of the founding members, along with 14 other centers, and pretty wild to think about how the movement has grown, and yet, as we've discussed, how many of the challenges remain the same 30 years later.
Mm-hmm. And I think the philosophy of what CenterLink offers actually is kind of the basis of my next question. How can community centers and FQHCs, that are serving the LGBTQ community, like learn to better collaborate and like fill in some of these gaps that might be within their systems by creating connections? What are some ways either you've been doing it already, or ways that you see as possibilities that we can create more collaboration in this nationwide system?
One way we have seen work is to not jump on the bandwagon if a patient comes to us and says, "Oh, I had a terrible experience at this other center in town when I went for reproductive care." They kept saying, "Well, are you here for women's health?" And not show support, but yet not widen the gap between us and that other community center. Instead, see them as a partner. We together form a safety net for our community. How can we collaborate, and how can we respectfully give feedback that we may have received from a patient, or maybe more than one patient, about a service snafu? And so that's some diplomacy, is something that I think is really important in the community between centers.
I'll maybe flip the question a little bit and put the burden on funders and the government to not pit organizations against each other for very limited amounts of funding. I think that's a huge problem. I think that our centers really want to collaborate, and a lot of them do, but they're also often in competition with other community organizations for very small pots of funding. It's not great from an organizational perspective, and I think it also can pit communities against one another. So, we have, is the money going to go to the LGBT organization or the BIPOC organization? When really the money needs to go to both. So I think, organizations like CenterLink exist to try to build bridges and connect organizations. That's our whole mission, and really we learn from the centers themselves who are doing it despite those obstacles. So I think there's a lot of great collaboration, and the more that each of us can try to, you know, foster that sense of community and shared collective responsibility, even just in how we interact with each other as humans, I think can really advance that goal.
That's a great point. I'm also thinking of how do we partner with for-profit, because as a nonprofit FQHC, we can't compete with the misters of of the world that are providing PrEP at a far discounted rate. And so, you know, we provide that full array of services, that primary care, that patient-centered medical home, and we have for-profits that are, you know, potentially something that we can't compete with. And so figuring out how do we do that? How do we advocate for that? Or advocate against, you know, that competition, both from nonprofits to for-profits. And then I think it's education with vendors. I think everybody likes to talk about how digital technologies are kind of great, AI's, you know, the landscape moving forward, but are we educating people on how these tools are going to be used to meaningfully connect with our patients and deliver that care? And I think it's something that we have a responsibility to be able to advocate and to educate them on. And so that's something that I personally enjoy doing is taking those opportunities to let somebody know, hey, this is how you can take care of us better with technology.
Mhm. You know, some words that all of you use, this idea between collaboration and competition. You know, some of the agency work that I've done, one of the things that can be really powerful is like, let's say you as an organization come up with a great new idea. Before moving ahead with it, look around in your community and see if somebody is already ahead of you in that process. And could that then become a collaboration versus, oh, well, we're going to take on this thing now. We're going to do it bigger, better, and we're going to get every dollar in the community to do it, and we're going to shut them down. Which, unfortunately, historically, I did a lot of work in the HIV and AIDS community. That is something we witnessed during the beginning of that pandemic. Everyone is competing for these dollars, and oftentimes at the challenge to clients themselves knowing where and how they could get services. So I think this idea may be replacing competition with collaboration and seeing who in the community maybe is already doing the work and maybe even doing it better than your brilliant idea as an organization.
I love that you shared that example, John, because that's it's a powerful reminder, you know, when the money becomes available from the feds, such as with the HIV, yeah, everybody's kind of like, we're positioned to do it. Let us do it. Let us do it. But yeah, who's ahead and who can we throw our support behind? And maybe then we can focus on something else and put our resources there in another way to support our community. I like that.
Yeah. So we're getting close on time, and we always have one question that I'd like to bring at the end of every one of these conversations. And reflecting on the conversation we've had today, looking at the work you're doing, the work you're hoping to do, what would you say is your hope or vision for the future of this community-based FHQC type work? What do you see as a vision or your hope for the future of this? And it's FQHC. I'm sorry, everybody. I think I've been doing it all the time today. Thank you all for gently not correcting me. So hope or vision for the future?
I would say that we can be proactive and not reactive. So I don't want centers to work themselves out of a job. I think that we'll always have a need for a special community for LGBTQ folks, but it would be great to be less focused on inequities and the latest terrible policy that's come out and safety concerns, and to be able to really have more time to celebrate and you know, keep on building our resilience.
I like that. I would put out there that we are wanting to normalize gender affirming care in healthcare as not some fringe specialty, but something that should just be, you know, mainstream in primary care, and have it, you know, destigmatized where there still is stigma.
Yeah, and I think normalizing it within the tools that we use to deliver care. They're not just something that's tucked away in the back corner of a software application, and that it just becomes part of somebody's chart. It becomes part of who they are. And it's just expected that we're looking at the person completely to take care of them, help them thrive.
Well, I want to thank you all so much for your wisdom, your experience. It's been such an honor having this conversation with all of you today. And for those of you who are joining us, you can hear the replay. It will be available coming up next week, and you can share it within your organizations and with others in the community who it could be powerful for them to hear and witness this conversation. Next month, we are going to be continuing with our Access to Care series. This time, we're going to be focusing on Middle Eastern and North African and being LGBTQ in America. We know the Middle Eastern and North African communities face significant health disparities and barriers to mental health care due to insufficient funding, discrimination, and unique challenges that exist within their communities themselves. We're often seeing higher rates of suicide, anxiety, depression, and really all of this is based on cultural and ethnic stories. So mark your calendars for July 18th at 6 p.m. Eastern Time, 3 p.m. West Coast Time, and every place in between. And you can sign up at outcarehealth.org/outtalk, and that's where you can also see some of our past episodes. Once again, thank you all so much for giving so generously of your time and your wisdom today. And be well, take care, and hopefully we'll see you all soon.
Thanks.
Thank you.